In 3, 2, 1. Hi, Tina Allen. How are you?
Nice to see you.
Good. Why don't you tell us what it is you do for a living?
Yeah, so I'm a physical therapist and I happen to specialize in the pelvic floor muscles and the pelvic girdle, which means I teach a lot of people about their pelvic floor muscles and how they work. And for my prostate patients, I teach them how to use those muscles again. And that's what I do all day long, a lot of hours a week, and just helping people navigate their way back to being continent again.
So uh, uh, let's see if you could do that for us now, if you could teach us about pelvic floor muscles. But I guess first we should start is this a real thing? It's just am I going to be straining my seat and not really get anything out of it?
Oh, so that's great. It is a real thing. And what we find is by teaching people to find their muscles well, meaning actually localizing their pelvic floor muscles, they can decrease the amount of leakage they have long term. We know that people post-surgery, once the catheter is out, will often have leakage and they always improve over a year span. But people who actually use their pelvic floor muscles and use it correctly and carry it over to function, which we'll talk about here in a minute, they get dry sooner. And so if we can teach people how to find these muscles and what they are and talk about why they maybe aren't working, and get people thinking about that, they can get dry quicker. So it is a real thing and it can be super helpful. When it's not helpful, it's when somebody's maybe doing it incorrectly. I don't want that to drop anybody away like, well, what's the point? But hopefully by the end of this, people will have a pretty good idea of how to find those muscles.
Sure. So as best as you can over Zoom, please teach us.
So I have a model with me. So I'm going to show this pelvic floor model. Let's see if I can move to the side. And this is a plastic model, and it really is for the muscles. And I use this with my patients every day to teach them about their muscles. And so here's a pelvis, and it's facing you. So when you're sitting, this is the area that's facing forward. They've taken the external genitalia off of this. So just realize that the penis would be here, the scrotum would be down. But here are these muscles. If we have somebody, I'm going to position this kind of sideways and realize that most people, when they think Kegel or pelvic floor contraction, they're thinking it's one muscle. They're thinking it's this lifting contraction. The pelvic floor muscles are actually made up of 3 different layers of muscles. And the first 2 are the most important, and they're the ones least talked about. So there's these muscles here that you're seeing that are surrounding the base of the penis and right at the base of where we sit. These are those bones that you sit on. And then this is the anal sphincter, or the area around the outside of where we have a bowel movement. That first layer of muscle is only inside about 1 knuckle, so barely inside, so it's really close to the surface. And this is the layer of muscle that closes the urethra. And we have to remember that as our prostate has grown in size, those muscles haven't had to do the work, because what that's done is pinched off the urethra. And so these muscles have kind of went like, I don't need to be working right now, because the prostate did that work for them. Then when we go in and we remove that extra tissue that's there, that prostate, any cancer that's present, these muscles are like, whoa, there's a flood of urine coming towards me down from the bladder, and it doesn't know how to control it anymore. Nobody taught us this, right? Like when we were getting potty trained between the ages of 2 and 5, somewhere in there, our only job was to figure out how to make these muscles work, but nobody taught us. And then they just did their job, just like walking. You just figure it out and you do it. That's the same things with these muscles. And so we have to learn after surgery how to use them again. So that was just the first layer. The second layer is a little bit deeper, and you can't see it on the model, but if I bring up a bladder, so here is half of a bladder. Let me see how I can hold this. Here we go. So here's the bladder, which is this, the top's been cut off. Here is a prostate, and then here is the urethra. The second layer of muscle, which is your external urethral sphincter, words you don't need to know, it's a muscle. It's right at the base of your prostate. And that one, more than anything else, hasn't had to work in a while the prostate was growing in size. If you don't use it, you lose it, okay? And so we want these first two layers, the ones I showed you on the model here, this first superficial layer, okay? And then this second layer right at the base of the prostate, we need it to wake up and start doing its job again. There is a deeper layer of muscle if I look inside. So now what I've done is I've taken out the internal organs and I've looked inside, and you'll see that whitish pink here. That's the deepest layer of muscle. The urethra, let's see, the urethra is right here. And I don't know if you can see the darker layer there. That's the first layer of muscle. It's nothing to do with that deepest layer. So the difference here, and the reason why I spend so much time on this, is to have people realize that we're supposed to use all three of those layers of muscle to close off the urethra, but the most important are the first two. And those have largely not had to function a lot because the prostate kept encroaching on there or taking up the space of the urethra. And those muscles are like, I don't have to work. And so if we can train those muscles to do their job again, because they'll learn again, but right now you have to take the time to do it, then we can start getting control back of when we go to the bathroom. We can get good closure of the urethra so that then we don't leak with cough, laugh, sneeze. We don't dribble during the day when we go to stand up or when we're just actually relaxing. And it also can help with erectile dysfunction in that the way that we keep an erection is that those muscles have to contract to hold that. And if they haven't had to do that in a while, this can help wake that up for folks. So those are the muscles, but what does that mean? Most of us learn, if we learn about Kegels at all, we learn lift, lift, lift. That's that deepest layer that doesn't go around the urethra very much. And so what we want to teach people to do more of is kind of a close, then lift contraction. So think of that as if all I did with my bicep muscle was contract it and just on, off, I would throw food at myself, right? I can't make this control to my face. Whereas if I learn how to use each muscle of the muscles around my elbow, then I can slowly bring the food to my mouth. The muscles of the pelvic floor are very similar. There's a finesse to them. And so what we want people to try to do is learn to seal the urethra and seal the anus, and then gently start lifting up the scrotum and the penis, or the external genitalia is the easy way to say that. So you close and then lift. And then what you're doing is you're giving a chance for those first two layers of muscle that have gotten weak and kind of lazy to start activating again. Because the human body is amazing. It'll compensate for anything. I just had an injury, and it's amazing how I'm watching myself have to compensate for things, but my body still gets things done, but it's not the old way of doing it. And so the fact that if we only know how to use that deepest layer, then that's all we use. And if we just slow down a little bit and get this more superficial layers, the more closer to the surface, the ones that close the urethra to work, then we can start shutting off the hose that is the urethra so that we don't dribble. How does that, what do you think? Questions on that at all?
So it's interesting that this idea of not using the muscles has such an extraordinary and almost durable impact on our lives. It almost sounds unbelievable that this, perhaps a year of not using a muscle would mean that it can't just instantly restore itself. How is it that if I'm 60 years old and I've now have an enlarged prostate, the prostate is doing much of the work, so the muscles get lazy for a year or two prior to surgery or radiation or whatever, surgery. How is it that, like, all of that prior 50-year history of successfully closing my urethra just gets forgotten?
Yeah, and that's a great question. It's not that it gets forgotten, it's that it gets weak. So if I've never ran before, or if I haven't run in years, the first time I go to the gym or go out for a run, my muscles get sore and it gets tiring climbing stairs. And so the muscle gets fatigued and tired easily. I don't think that we actually forget. It's just that it hasn't had to do the work. And so the bladder is a muscle and it contracts. And so if that bladder muscle is contracting harder than the muscles that surround the urethra can contract, that means if the bladder is giving us a little urge and those muscles aren't strong enough to meet that contraction of the bladder, urine's going to dribble out. So it's more of a strength issue with a little bit of forget, but it's a strength issue more so than it is that it's forgotten how to do it. The body really quickly remembers once we go, oh, that's right, I'm supposed to be controlling this. It gets, I guess, lazy and weak instead of completely forgetting. Like, we haven't lost the neural input. Like, our brain goes, there's something supposed to be happening here, but I'm not sure what it is. I need a little help with that.
Is there some impact by depression or positive impact from, I don't know, stress relief or a positive attitude that impacts this one way or the other?
I am sure when we think, not for sure, but if I think about it, if somebody is depressed and not moving around as much, their muscles get weaker. The more we rest about and we are not moving as much because for a lot of my clients, they don't want to go out because they don't like all the leakage that they're having. So they're embarrassed, so they stay at home. That lack of movement decreases our muscle strength. And so it's definitely it's a couple off. It's not a direct result of, but by not being as active, yeah, our muscles get weaker and then they don't work the way they should.
Do you think certain professions have better outcomes than others?
I see I'm at the University of Washington and we see such a huge amount and diversity of clients. I haven't found any one more than another. What I do find is the fitter somebody is going into surgery, usually the better their outcome is. So it seems to be the more exercise somebody does before surgery, the quicker they recover after. And that's true for your pelvic floor strengthening. If somebody started doing pelvic floor strengthening before surgery, we find that they recover and have less incontinence after surgery. So I think there is more about just keeping those muscles working throughout our whole life that is of benefit for us.
Yeah. And, even though this is a virtual conference, I could hear thousands of people behind me asking questions. And a bunch of them are coming from guys newly diagnosed as yet, not yet about to do a concrete kind of treatment, or guys in active surveillance. And they're all shouting in the back of my head, but I'm leaking already. I'm aged into a period of time where I leak before going to sleep, where I'm maybe using a pad in my bed where I don't empty myself enough in a toilet and sometimes have to return rather quickly, or there are drips on my underwear and such. Am I pre-doomed to not have a successful outcome if I do a series of Kegels and such?
So if they did Kegels now, if they strengthen their pelvic floor muscles now and learn how to isolate that muscle as they go forward, things will improve. So it's never too late to start strengthening your muscles, and you're not doomed to continue having the same thing that you're experiencing now or for it to get worse. If somebody starts strengthening their muscles now, we tend to find that at least 80% of folks do way better going forward with whatever treatment approach is utilized. So no, they can get better now, and they can have better recovery later.
Why is it that some men after surgery don't get better? I mean, men who are diligent about Kegels and everything else, you know, they don't fill their bladders more than, 3 hours prior to sleeping or whatever, but they suffer egregiously for the rest of their lives. What's that about?
That's where, we work with our surgical partners, our surgical docs, and trying to, there is this, I'm going to grab another little model here. If I can find it. Oh no. So I'll show it with this balloon. So if we look at this, this is a bladder. This is my fake bladder. And you can see where the knot is here. Let's call that the prostate. There's another internal muscle that we're not in charge of. It's called your internal sphincter, and it's right at the base of the bladder, and the prostate tends to surround it. And when somebody's having a lot of long-term issues, we're concerned that because of where the cancer was, possibly that internal sphincter, that internal muscle that we're not in charge of, we can't strengthen that muscle because it's not under our voluntary control. We're concerned that possibly part of that muscle had to be taken to get rid of all the cancer. And then also it could have grown into, and underneath that little knot would be where that external sphincter is. That one is under our control, but did some of that have to get taken also? So it could be that there was something due to the cancer that encroached on those muscles that then we can't recover because part of it had to be taken, or if we're under surveillance, that part is being affected now. So that's the challenge is while, of course, as a physical therapist, I feel that by getting muscles to work, usually we can get people significantly better, but sometimes just the nature of the disease that we have may be affecting those areas that we can't recover from.
Yeah, and it raises a marvelous point in that 99 out of 100 men will be concerned. Will you, ask their about to do surgery, ask their surgeon, will you preserve the nerve bundles, for erectile functioning? Almost on the other hand, the flip side, maybe 1 or 2 out of 100 will say, will you preserve the bladder neck? Will you keep, they may say, will you keep me continent? But there's no precision in conversation around, I want my bladder sphincter and my to work, do your best around that. And through our support group network, we know that as much as we care about erectile functioning and we want that restored and we want it never to have a negative impact from many of the treatments, it's urinary incontinence that keeps a guy home. It's urinary incontinence that keeps them off of planes when, and hope we can keep flying some more, impacts their work, fear of odor, fear of this and that, discomfort in wearing diapers, rashes, pads, and we could go on.
Right.
But yeah.
Well, I do feel, at least with the I've talked to across the country, one of their primary, while the patient may not be asking because they don't know that that's what they need to be concerned about. But I do feel that our surgeons do the best they can to preserve all those things because they want their patients to be continent also and to live this full life after and not be limiting. But sometimes it just can't be preserved. And so then what do we do? And so that's when a patient will come and see me or somebody like me. And we try to make those other muscles that I talked about compensate for that. So can we build up there's 3 layers of muscles, remember? And so if the internal sphincter had to be taken or isn't patent anymore, those other layers of muscles should be compensating for it. So if we can get somebody to strengthen those muscles, and then also do some timed voiding, meaning make sure, you know, normally we go to the bathroom every 2 to 5 hours when we don't have any kind of conditions. And so let's make, and a lot of my patients are like, well, I used to go every 8. And I'm like, well, that wasn't healthy then. And so let's change that now and have people make sure that they're timing themselves and they're going to the bathroom every 2 to 4 hours and emptying their bladder. And then that muscle is working to keep things sealed. And so we try to compensate for any loss that had to happen due to the surgical procedure or treatment or radiation, because radiation can make that tissue kind of tighten and restrict so it doesn't close as well. So we do our best to accommodate, and the human body has an amazing ability to do that. So by getting folks to strengthen these muscles, and I think one of the key things to realize is when we read online or maybe, and I struggle with it, some of the docs I work with, and I work next door to them, they hand out a piece of paper that says, stop your urine flow, and that's how you do your Kegels. And that's not the greatest way to do a Kegel, because you could cheat. You could use your butt muscles, you could use your abdominal muscles, you could use a lot of different muscles instead of your pelvic floor to cut off your urine flow. So if we can teach somebody to think about, it's a subtle contraction, most of your life you never knew it was happening. So it's not this big, robust, let me get tighter and pierce my lips and raise my eyebrows kind of contraction. Nobody needs to know that you're doing them. You can be sitting here very calmly and think about closing the urethra, winking the anus, lift the genitalia up as if you're walking into some cold water, or think about it as an elevator where you squeeze in a little and hold for 2 seconds, and then you go to the next floor and hold for 2 seconds, and the next floor and hold for 2 seconds. And the whole time you're breathing, you're not holding your breath to do it. And you're not getting taller because you're using the wrong muscles, because nobody can see it. And that's like the starting point. The next thing to do with that is to make sure you're doing it in different positions. I always have this joke with my clients and my colleagues about, if you only do pelvic floor contractions or Kegels at stoplights, you're only going to be continent when you're sitting in a sitting position, because that's what you're training your body to do. You become a better baseball player by playing baseball, by throwing a ball and batting, right? So if you leak when you stand up, or if you leak when you go to pick something from the floor, that's when you should be practicing doing a Kegel. So it's just another muscle. It's just a muscle we don't talk about. It's private. We don't talk about these things. But actually, this muscle gets trained just like any other muscle. So let's make sure that, start doing these Kegels in an easy position that you're really successful at, sitting, laying down, but then take it to standing and stand with your foot up on a step, or stand with yourself like leaning against the wall. And if you can do a little bit of a squat safely, go ahead and do that, so that you teach your body that the muscle is supposed to work in all these different positions. And you've made me very conscious of, the body remembers. It's that it kind of forgot it was supposed to do it there. And so give it the cues to remember to do that in those positions so that then you can decrease the leakage with your daily tasks.
I'm guessing that many of the questions you have are quite similar in this respect. How do I know I'm doing the right muscles?
And that's always the challenge, especially like right now in the time of COVID, where a number of my patients aren't coming into the medical center. I'm seeing them via telemedicine. Normally when I see a patient, I'm observing their pelvic floor muscles. I'm looking at the external part of their body, but seeing how they do it. And how do I now, when I'm talking to all the people behind you and with you, as well as via telemedicine, how do I make sure? The biggest thing is that I tell people that if they notice that I want everybody to think about closing those openings, and it's really subtle. It is a wink that you shut your urethra it's a wink, it's not big. And then you try to lift those tissues off the chair that you're sitting on. If you notice that you're getting taller, that means I'm using my gluteal muscles or my buttock muscles. Those aren't your pelvic floor muscles. And then if you notice you're getting thinner, like your waistband is going in, those are your abdominals. Those aren't your pelvic floor muscles. So really, it's a sensation. And for some of my folks, pre-surgery, in waiting period or deciding what to do with, they can feel that area. But some people post-surgery for a period of time, that area, they don't feel as much. So that may be where I say to somebody, if you're comfortable, could you maybe touch right below your pubic bone, so above your genitalia, and then maybe back near your tailbone, and you could feel with your fingers, do I feel movement happening? And can I feel that kind of lift? We could have them try, when they go to the bathroom, shut off their urine flow, but I don't want that to be the only way somebody does Kegels. The reason for that is it starts kind of messing up our body's intuitiveness of being able to empty the bladder all the way. If we sit there and we stop the flow of urine repeatedly, it messes up that mechanism that the bladder empties fully. So we don't want to do, I had a gentleman that I just saw a few months ago that he was doing 300 urine stops a day. And he was having all this trouble emptying his bladder. And the minute I told him, like, stop doing that. I want you now just to use that idea and do your Kegels, not when you're going to the bathroom. Suddenly he was emptying his bladder just fine. It was just messing up the signals. And so we wanted to stop that. So hopefully that gives some ideas about how somebody could feel. They could feel with their hands. They could notice if they're cheating, quote unquote, cheating. We don't mean to, but using the wrong muscles.
So if not 300, how many, how often, what do you suggest for folks?
What we know is anywhere from 30 to 60 a day, people get stronger. And you don't have to do it all at once. So I tell most of my patients 15, 3 times a day, put an extra set in there if you have time. People who do over 80 a day don't get any stronger than somebody who did 60. So we know that like 300 a day, what actually happens with 300 a day is people's muscles get too fatigued, and then they end up leaking at the end of the day because they fatigue the muscle so much. So 30 to 60 is great. I tend to push people to the 60, but 30 to 60 a day is perfect. And you can just spread it out during the day. If you sit there and after 15, you're going, I don't know if I'm doing this right anymore, take a break. Do another set of 15 later on. But if you feel like at 20, you're like, yeah, I got this. Great. You could do them all at once. No harm, no foul there. But it's more about quality, not quantity.
And once you get for guys who have success, I mean, is that it? No more Kegels for the rest of their lives?
So we look at it, and one of my mentors always said this, that we look at Kegels as like, oral hygiene. You brush your teeth every day, right? And so with Kegels, once you're doing great, you're not leaking, or you're not leaking very much, you're satisfied with where things are. I tell people 10 most days. So every time you brush your teeth or every time you wash your hands, do a few Kegels. That should maintain the muscle strength. If you notice your symptoms getting worse, doing 10 a day wasn't enough. You need to bounce it back up to maybe 20 or 30 for a while, and then see if you can drop it back down. But what we've seen is 10 to 20 most days long term keeps the muscles working. And conceivably what's happening also is that the muscle's just activating on its own like it used to. And so then that activity is there for you too.
So it's not really reminding, it's restoring.
Storing, that's a much better term. Yes.
Yeah. What are there like funny, helpful hints or funny anecdotes you have around this?
Um, so the other thing I always say to people is that you can fit Kegels in anywhere. Every time you wash your hands, do 5. Nobody else is there with you at that time. And think about where you leak and when you leak, and do your Kegels then. And so I spend a lot of my time teaching folks how to fit things in. I'm trying to think of anything else. I feel like putting on the spot for funny. I try to be funny, but not always. The other one to consider is that sometimes there's always these big questions for patients about what's okay to drink, what's not okay to drink. And for folks with prostate cancer, it really varies. A lot of people, what you drink doesn't matter. For other people, it does. And the things that can irritate bladders and make people leak more, there's 5 big ones, and they are caffeine, citrus juices, artificial sweeteners, carbonation, and alcohol. And most things that I get asked next is what's left. And what I say to folks is, you don't have to get rid of all of those, but if you're having more leakage one day, let's say, today I had an extra beer. Maybe I usually only have 1 beer with dinner, and it was social. I don't know if it's social right now, but it's social, and I had 2. And I noticed the next day I'm leaking a lot more. Well, then that second beer probably was the cause of it. And then I get to make my own adult individual decision about when I have a second beer again. And so you don't have to get rid of all those things, but you can always look back 24 hours later and be like, what was different? What did I consume that was different? And then notice if that's a pattern for you. And then you make a decision whether it's worth it for you. And I don't judge that. That is really up to the individual. But realizing that some of the things we can consume can affect it, but not always. So that would be the little snippets of things I always make sure I tell folks.
Do you think it could be a couples thing, both for gay and straight partners?
In what regard? What do you mean?
Everyone doing their Kegels together.
Yes, totally. Yeah. And so, I always have partners coming in and with patients, and they do it together to help both have a nice, strong pelvic floor for the long term. Because we don't know, we're just learning. Continence has in the past 5 years gotten a lot of support by research. And there's literature coming out saying, like, if we are more consistent with our pelvic floor strengthening, long term, we have a lot less deficits or problems. And so, yeah, if we can take pelvic floor strengthening and keeping our pelvic floors working well, hopefully long term, people have just a more robust life because they're not limiting themselves as much.
One of the themes of our conference is around disparities. Do you find particular cohorts of people, gay, straight, black, white, younger or older, athletic, not athletic, you mentioned earlier, respond differently to Kegels?
I think um, the distinctly, what it is who's open to what I have to present and teach somebody. My significantly older folks, so I'd say 80s and 90s, some of them come in, they're like, what are you, no, my doctor's making me be here. Um, and then I do feel that the African American patients are a little more reluctant to come in, but once they come in, usually with their partner going, you have to do this, they really see a huge benefit. So I haven't noticed any populations that don't do well once we teach them how to use their muscles well. I think there's resistance to getting care. And then once they come in, they realize that it's not as scary as it sounded like it was going to be. And then I can meet them, and any pelvic health PT can meet them where they are and what they want to learn.
Sure. And, part of the resistance to seeking care is that around prostate cancer, there's almost too much care. You see your primary doctor, then you see your urologist, then you see all the anesthesiologist and nursing and physician assistants and blood drawers and everybody else, and then you have to deal with insurance and not, and to have one more appointment is toxic in and of itself. I'm saying this so that people who feel resistant for that reason, you're not alone, and it's a perfectly human and almost healthy response to being bombarded with demands on your time and investigations into your body just because you got diagnosed, which wasn't your fault.
Right. And what I say I see patients who are, and first, one thing to realize with pelvic health PT is you see us once, and then usually we kind of send you on your way working on things, then you see us again a few weeks later, and it's maybe 2 to 4 sessions. So it's not a lot, but the other part of it, it's never too late to come to pelvic health PT, meaning all of those appointments that people are going through when they're in active care, I'm like, yeah, it's overwhelming. And you know what? I'll be here a year from now and we can still make your muscle better then. And so I always tell patients, if they're reluctant, like I would love to see them once during their care just to get them going and doing their pelvic floor strengthening well and answer any questions they have and fill in any gaps I can. But then I'm not going anywhere, and neither are other pelvic health PTs. We can regain muscle function back, 3 years from now. It's better to treat it early, don't get me wrong, but it's also like we can try and see what we can do later too. So get it.
For those who are like in rural areas where transportation to getting anywhere is a time sink and a demand that they may not particularly be happy about, and those in lesser developed countries who are watching this, online, are there ways to completely learn this remotely, even from just watching a YouTube video? Is that enough?
I really think so. I think people can do a lot on their own. There's so much on the internet now. And there's books. I'm trying to think of the name of the book that I usually recommend, but it's escaping me right now. And people can do great that way. And then there's also with the advent, with one wonderful thing about COVID-19, the one wonderful thing is that, physical therapists weren't allowed to do telemedicine before this, and now we are. And so folks who are in rural areas in the US and in Canada can actually reach out to a provider in their state that may be hours and hours away and meet with somebody like this and have a discussion about, okay, what are you experiencing? How are you doing? We won't look at your private area, but we can be like, okay, back up the camera. Let me see what you're doing with you fully clothed, and try to make sure we're not seeing the typical cheats that we see. And there are pelvic health PTs all over the world. I was teaching a class about 3 months ago, and I had 4 PTs from India and 3 from France online learning. So we're around, and we are here to help as much as we can.
Good that you mentioned India, because the next question is around comparable activities. For example, I mean, I don't know what there might be in Indian culture or Indian care besides the traditional Western care. I mean, I guess Ayurvedic is not really the place to look for something comparable, but yoga, things like that. What are the things that are done in places other than the West that are comparable or perhaps even better than Kegels?
Oh, I don't I don't have an answer to that. That's a great question. I think when I talk to folks who live in other countries, we teach people pelvic floor strengthening, and then we also teach them how to strengthen up just their hips and their core muscles in general, because we know that can help. Um, and I think it is pretty much the gold standard in care, is actually strengthening these muscles in that way. I have had patients tell me that acupuncture is helpful. And then I've had other patients say that it isn't. So I think it's worth trying and hearing what else their countries do, but I don't know what other people are doing. Everything I hear is core strengthening, hip strengthening, pelvic floor strengthening.
Okay. And you mentioned a book earlier. You will remember that book. You will email me and I will include a link or a mention of it below,
Yeah,
or somewhere in the virtual goodie bag that our
yeah.
attendees get. A couple more things and then our time is running. You mentioned erectile dysfunction benefiting from this. How does that, talk a bit about that, please?
Yeah, and so when by getting these muscles stronger, especially those first two layers, the names are bulbocavernosus, ischiocavernosus muscles. By getting those muscles stronger, when we have an erection, those muscles need to contract to hold the blood and to hold the erection. So if these muscles have gotten weak over time, then if we can have the arousal, it can't hold the blood in the penis. So then that can be part of the erectile dysfunction. If we get these muscles stronger, that can help hold the blood in the penis and allow for a longer erection, a better erection, and then being able to have ejaculate. So while it's not like just doing pelvic floor strengthening I will say will not cure ED, but by what I've heard from so many of my patients and we read in the literature is that doing all the things their doctors have recommended around ED and then adding in pelvic floor strengthening, a number of my patients have said like, that was a ticket to get me further along, to help me out with being able to hold longer. And then to actually, it doesn't necessarily help get the arousal to happen, but it can keep the erection happening.
Okay. Kegels or Kegels?
I don't know. My mentor always said Kegels, and then people always correct me and say Kegels. And he's an actual doctor, Arnold Kegel or Kegel, and from the East Coast is who coined that first. And I don't know what the correct pronunciation is.
Is he still alive?
No, he's passed.
Ah, maybe I should call a family member and ask. We'll try and we'll get to the bottom of this. Yeah, maybe for our next conference, but certainly sometime. That's on my pre-New Year's Eve to-do list. Tina Allen, thank you very much for sharing your wisdom and your experience and for caring for our community. And welcome to the conference.
It was lovely. It was so good to get to meet you, Darryl, and all the people behind you. Thank you for that.
Thank you. Bye.
Bye.